Well, here we are at chapter 45 in Geriatric Emergencies. This chapter is actually broken down in, I believe, about 5 different parts. In this first section, we're mainly going to get into kind of the background of things that relate to geriatric patients. And with that, we'll just go ahead and get started. So, geriatrics, of course, focuses on the evaluation and treatment of diseases in people aged 65 or older. As of the 2020 census, there were about 54 million Americans that were over the age of 65. That's about a 34 and some change increase compared to the census that was done in 2010. Older adults make up about 20% of all emergency department visits, and people 65 and older represent a growing share of all patients throughout the healthcare system. And this is becoming especially true with better technologies, better equipment, better treatment plans, and those kinds of things. We're seeing adults live to longer ages. The old age dependency ratio measures how many older adults there are for every 100 adults aged 18 to 64. It helps compare how a single society's age structure changes over time. And it also allows comparisons between the age structures of 2 different societies. The term graying of America refers to the growing number of older adults in the population. In 1990, there were 20 older adults for every 100 working-aged caregivers. By 2018, that number had rose to 24 older adults for every 100 working-aged people. The number of caregivers is not growing near fast enough to match the aging population. The demand for caregivers is projected to continue to rise. As the population ages, meeting the needs for services will become increasingly more challenging. There is an increased need for services that are both cost-effective and efficient. Most geriatric patient EMS encounters do not live in nursing homes, so the majority of them are still living at home. They're living with family members. They may be even living in assisted living or facilities similar to that. Nursing home admissions are rising as the older population grows, but at the same time, many older adults are choosing to live independently. Older adults may live at home with the help of spouses, family members, or maybe even a visiting nurse or other caregivers. Some live in dependent care environments like senior living centers. Others may reside in assisted living centers, while some of those are still going to require full-time care in what's a skilled nursing home or a traditional nursing home that we're all familiar with. Marital status can actually have a significant impact on whether or not someone lives alone or with a partner. Financial resources are often a determining factor of what types of care or housing are affordable for a particular person. Religious beliefs may also guide preferences for living environments. Ethnicity can influence cultural expectations around caregiving and living arrangements. And gender may play a role in support systems that are available resources that are out there. General health affects the level of care and type of housing that a person might need. So depending on their healthcare needs, will play a major role in what kind of living conditions are going to be best suited for them. Decisions about our older adults' living situation can create stress for adult children and other family members. Healthcare providers should consider the family's needs and input during the decision-making process. Families may turn to medical social workers for guidance and support in these instances. Professional care managers can help to coordinate some of those appropriate care options and navigate that very confusing system to get through. Discharge planners at healthcare facilities can often assist in planning next steps after hospitalization, and families may also rely on various public and private resources for help. A range of services are available to seniors, and these are going to include delivered meals such as Meals on Wheels or church-based services that do that, personal care, housekeeping, adult daycare, transportation, caregiver support, respite care, and even emergency response systems. But realize each one of these comes with a price. There's a price tag on each one of these. So depending upon what insurance or financial means that particular patient has is going to be a big determining factor on which ones of those services they're going to be able to take advantage of. As mentioned, an older adult's financial situation is going to strongly influence where they live and what services they're going to be able to have access to. Not all retired individuals enjoy a large range of financial comfort. Older adults who worry about having enough food often experience poor nutrition. They are also more likely to report poorer overall health. Limited financial resources can reduce their ability to care for themselves. And of course, older adults living in poverty may make risky choices to cut costs in order to be able to pay their bills and to do things that they need to do to survive. Some may skip medication doses to save money or completely opt not to take a particular medication. Others may use unsafe heating sources like kerosene heaters instead of central heating in order to cut costs and to save money. Psychological factors play a major role in aging as well. The feeling of being unproductive or left out of society can lower an older adult's self-esteem and create a whole host of problems. Many experience frustration when they can no longer do things as easily as they once could. Some mourn the loss of activities they once used to enjoy, and others may feel a sense of freedom or accomplishment after retiring. That's what we all hope for, right? Older adults may face a crisis of integrity versus despair. Integrity means feeling proud of one's life accomplishments, but despair arises when someone feels that they haven't met all of the goals that they'd hoped to meet. The loss of friends and loved ones often leads to feelings of loneliness and isolation. The death of a spouse can create a serious financial strain, especially for lower income families without retirement savings or life insurance. If an older adult relied on their spouse for daily help, they may need support from children or other sources to meet those basic needs. So let's do a bit of a review of the geriatric anatomy and physiology. I feel like this was talked about somewhat probably all the way back in your anatomy and physiology class when we talked about the aging process. But let's revisit that so that when we get into some of the very specific diseases and illnesses and those processes and how they impact the body, the understanding will be a little bit better, knowing that how the geriatric anatomy and physiology responds to those things. So the aging process, it typically starts in a person's late 20s or early 30s. So I got news for you. Many of you that are listening to this are either in the early stages of the aging process or fixing to be, or maybe in a little bit further in those. So aging is a linear process, meaning functional declines happens at a steady rate over time. So it's a progressive, it's a slow process. It takes you 20 years to get to your peak, and the rest of your life, whatever that is, typically it's another 60-ish years, hopefully for most of us, 60 to maybe 70 years after we hit 20, that things will decline over time. Now, it is a linear process, so a 35-year-old and an 85-year-old age at the same rate, but the older person shows more of those long-term effects. So at 35, you're aging at the same rate you will at 85, but it's gonna be more evident by what's going on. Aging in organs and tissues can be sped up by several factors, so poor living is going to have an influence on that, as well as genetic traits can influence how quickly some ages. There may be even some pre-existing medical conditions that kind of push things along. Of course, things that we can control are things like poor dietary habits, exposure to environmental toxins, having low levels of physical activity. Those are linked to faster aging. And including psychological and social factors can actually have some effect on the way that someone ages as well. So being active and involved in society can further help to slow that aging process. Nothing's going to stop it, but there's some things that can slow it down. Of course, aging is going to vary significantly from one person to the other, as we talked about some of those genetic factors and those kinds of things that we're not in control of. But as people age, their bodies undergo changes in physiological function. All tissues in the body age, but they don't necessarily age at the same rate. It is normal for an organ system to lose some functional capacity with age, which can affect how the body responds to illness. Older adults may show different signs and symptoms than younger individuals with the exact same condition. Illnesses in older adults may last longer and have more serious consequences. Age-related changes can influence how healthcare professionals interpret and respond to illness in older patients. It is crucial to distinguish between normal aging and acute changes that may indicate disease. Understanding a patient's baseline functional status is essential when providing care to older adults. Respiratory capacity increases significantly as people age. Lung elasticity is reduced with age, and the surface area of the alveoli becomes smaller. Respiratory muscles lose some of their size and strength over time, and then there's also some calcification of costocondyle cartilage that makes the chest wall much stiffer. Vital capacities decrease, the residual volume increases, the total amount of air in the lungs stays the same with age, but things just become, the airway, portions of the airway of the lung and all that stuff begin to get smaller. Airflow becomes less efficient. Breathing becomes faster and more shallow with age. And blood flow distribution in the lungs begins to drop in oxygen levels. The respiratory drive actually weakens due to reduced sensitivity to changes in blood gases or decreased central nervous system responses. Musculoskeletal changes like kyphosis can reduce lung volume even more and limit the maximum inspiratory pressure that's available. Chest expansion becomes more difficult due to loss of muscle strength and mass, making breathing more energy demanding. That's why it's critical to stay active and physically active and moving so that those age-related muscle losses can be mitigated to a degree. These age-related changes also reduce the respiratory system's ability to adjust tidal volume or respiratory rate in response to stress or illness. So unable to respond to, when there's stress or an illness, like pneumonia or something. The lungs' natural defense mechanisms become less effective with age. Cough and gag reflexes weaken over time, which lead to an increased risk of aspiration. And the number of cilia in the airways decreases, reducing the ability for the mucus and debris to be cleared from the airway, increasing the likelihood of pneumonias and those kinds of things kind of setting in. The cardiovascular system, on the other hand, begins to become less efficient as the body ages. The walls of the left ventricle typically will thicken, and the blood vessels lose their elasticity. This leads to an increased stiffness, especially in the coronary arteries. Arteriosclerosis can lead to systolic hypertension and is often linked to conditions such as diabetes, atherosclerosis, and even kidney disease. Arteriosclerosis increases the risk of cardiovascular disease and overall mortality. Vascular wall flexibility depends on collagen and elastin, which are key structural proteins in muscle and connective tissue. Normal aging leads to increased blood pressure, which causes collagen overproduction and a reduce in elastin. These changes stiffen blood vessels, leading to widened pulse pressure, reduced coronary artery perfusion, and less efficient cardiac ejection. Aortic sclerosis occurs when the aortic valve thickens due to fibrosis and calcification. This thickening can block blood flow from the left ventricle and lead to aortic stenosis. Peripheral blood vessels become less elastic, contributing to elevated blood pressure. These stiffened vessels increase the risk of peripheral vascular disease, causes reduced venous return, and dependent venous pooling, as well as stasis ulcers. The heart's electrical conduction system will also change as we age. The number of pacemaker cells in the SA node decreases over time. These changes can lead to bradycardia, which may reduce cardiac output. The aging conduction system may struggle to increase heart rate in response to low blood volume or higher metabolic demand. Some cardiovascular changes due to inactivity rather than aging itself. In older adults, heart rate rises more slowly during activity and takes longer to return to baseline afterwards. So we don't respond to near as well. The process is slowed. The nervous system, on the other hand, a neurological exam will reveal changes in the nervous system that are related to aging. The brain loses weight and volume as a person ages. Despite these changes, the brain has a reserve capacity, so reduced size does not always impact mental function. Declines in mental function can affect the regulation of various body systems. Aging may actually reduce control over the respiratory rate and depth. Pulse rate regulation can also decline. Blood pressure regulation may become less and less stable. The sensations of hunger and thirst may decrease. That's why as we age, we often begin to lose weight. Reflexes tend to weaken with age. Temperature regulation and perception becomes much less effective. Older adults are less able to recover from extreme temperatures, and they may also be less likely to recognize harmful temperature exposures. Sensory changes is going to include vision, hearing, taste, and even tactile sensations. But it's important not to assume that all geriatric patients are blind or deaf. So we want to make sure we use the same communication techniques that we would with anyone else. If the communication is ineffective, we're going to gradually modify those techniques to fit the patient. Visual changes will typically begin as early as the age of 40. Tear production will often increase, and there may be a sensation of dry, burning, or itchy eyes. There may be an increased chance of mild eye injury or infection during this time. With age, the lens becomes more rigid and restricts accommodation. Those ciliary muscles lose their ability to contract, and muscle tone decreases. This can affect the pupil diameter, refractive errors, night vision, sensitivity to glare, and even peripheral vision. Most common visual disturbances include things like cataracts, which is the result of hardening of the lens over time. What happens is the lens actually eventually becomes opaque, preventing light and images from being transmitted to the rear of the eye. Patients may report blurred vision, double vision, spots, ghost images, and decreased color perception. Glaucoma, on the other hand, is an increase in intraocular pressure that damages the optic nerve. It can lead to permanent peripheral and central vision loss. Treatment is going to be oral medications and eye drops, or maybe even a combination of the two. Other possible causes of vision loss are going to be age-related macular degeneration, retinal detachments, and diabetic retinopathy. Visual and auditory declines, visual acuity declines with age, even without disease. Older adults often have trouble seeing in low light or at night. They may struggle to adjust quickly to changes in lighting, depth, and color perception, and vision changes can impact independence, reading ability, and driving skills. Oftentimes what we first notice is we begin to have difficulty focusing on objects once we start to bring them closer to our face. This has to do with the stiffening of the lens of the eye, and the muscles of the eye can no longer contort that lens to where that we can see things close up. Often this is kind of the first indication of that, and where we're having to buy some reading glasses to be able to see things close up. Gradual hearing loss is also common with aging. There's this presbycusis that causes progressive hearing loss and makes it harder to distinguish sounds from background noise. Hearing loss can reduce the ability to understand speech and communicate effectively. Hearing loss may pose safety risks since many warning signals rely on sound. Hearing aids contain, this little microphone and an amplifier to improve hearing. Some hearing aids fit entirely inside the ear canal, but most hearing aids are powered by batteries. Hearing aids can be expensive and are not always covered by insurance. And what they mean by expensive is these things can cost $5,000 to $10,000 a piece. So whenever you're taking care of somebody's hearing aid, make sure that you keep track of them, because they are very expensive to replace. This is especially true. The smaller the hearing aid, the more expensive it is, because it's more convenient. So just be aware of that and how expensive that they are. Meniere's disease is a hearing disorder that usually begins in the middle ear. Symptoms are going to include cycles that can last for several months. Common symptoms are going to include vertigo, hearing loss, tinnitus, and the feeling of pressure in the ear. Appetite changes occur gradually with age. These changes may be caused by fewer taste buds, medications, viral infections, or upper respiratory conditions. Sensitivity to salty and sweet taste tends to decline at first. Aging causes the loss of nerve fibers, which reduces the sense of touch. A decrease in the sense of touch can lead to slower reflexes. The sense of smell is usually the last to decline, and viral infections can also impact the sense of smell, as we've learned with COVID. COVID was one of those that can impact the sense of smell and taste. Physiological changes make it harder for older adults to speak loudly, clearly, and with proper pacing. Speech difficulties may result from weakness, paralysis, hearing loss, or even brain damage. Cognitive decline can affect speech when the person struggles to recall information quickly during conversations. It's important not to rush or interrupt an older patient while they are speaking. Proprioception, or the body's sense of position in space, may worsen with age, leading to postural instability. And of course, this is going to depend on joint receptors and visual cues. As the senses decline, older adults may become less steady and more prone to falls. Other sensory changes can make balance problems even worse. Aging-related changes in digestion actually start in the mouth. The number of taste buds decreases, and the changes in olfactory receptors reduce taste and smell. Saliva production declines and causes the mouth to dry out. Tooth loss often occurs due to tooth and gum disease and not just aging. Ill-fitting dentures can raise the risk of choking, heartburn, and abdominal pain. Gastric secretions decrease with age. A weaker esophageal sphincter lets stomach acids enter the esophagus, causing heartburn, indigestion, esophageal scarring, and acid reflux. These symptoms are often linked to diet and eating habits. Some symptoms may signal heart problems and should be evaluated carefully. Gastric motility slows, leading to delayed stomach emptying. Slower gastric emptying increases the risk of aspiration and worsens heartburn and acid reflux issues. The small and large bowel function changes very little with age, but decreases But diseases like diverticulosis become more and more common. The rectal sphincter may shrink and weaken, leading to fecal incontinence. Slower peristalsis often causes constipation in older adults. Constipation can be caused or worsened by certain medications, dietary changes, and decreased physical activity. It may lead to difficult, strained bowel movements that increase the risk of hemorrhoids. Straining too hard can cause fainting or syncope or slow the heart rate. Patients may try to manage constipation with diet or medications that are not always appropriate. Overuse of treatments can result in diarrhea, which may cause dehydration. Liver enzyme systems change with age. Some decrease in activity while others increase. Enzymes that detoxify drugs tend to decline. This decline can affect how drugs are processed, increasing the risk of toxicity. Taking multiple medication raises the chance of liver damage and drug toxicity in older adults. The kidneys maintain fluid and electrolyte imbalances. They also help to regulate long-term acid-base balance. Kidneys play a major role in eliminating drugs from the body. Kidneys decrease in size and weight until about the age of 40, then begin to shrink. Kidneys increase in size and weight until about the age of 40, and then they begin to shrink along with the body surface area. Aging causes a loss of functioning neurons. Of course, this is further complicated by, uncontrolled high blood pressure or even diabetes is going to cause a faster loss of nephrons. The effective filtering surface of the kidneys becomes smaller and smaller over time so that it's not actually doing its job as well. Acute illnesses frequently lead to fluid and electrolyte imbalances in older adults, and the aging kidney responds slowly to things like a sodium deficiency. And this allowing significant sodium losses before the urinary excretion stops. The issue is worsened by a reduced thirst response in elderly patients, and as a result, severe dehydration can develop. Older adults are at risk of overhydration when they consume large amounts of sodium due to a reduced glomerular filtration rate. They're also vulnerable to serious or even fatal hyperkalemia if they develop acidosis or if potassium intake increases from any source. About 26.8% of U.S. adults age 65 or older have or are suspected of having diabetes. Older adults have a higher risk of developing type 2 diabetes. Carbohydrate metabolism in older adults becomes less efficient. Insulin production and glucose metabolism gradually begin to decline, and medications for other health conditions may also affect that glucose metabolism rate. The antidiuretic hormones may increase with age. This can cause electrolyte imbalances and problems with fluid balance. Peripheral edema, such as swelling in the feet, may develop, so it's important to know the patient's baseline. Additionally, menopause leads to reduced hormone secretion, especially that of estrogen. Lower estrogen levels can decrease bone density and increase the risk of osteoporosis. Aging affects every part of the immune system. Older adults are more vulnerable to infections and related complications. Chronic conditions like diabetes, dementia, malnutrition, cardiovascular disease increases the risk of infection. Infections may show different symptoms in older adults, so be aware that fever often signals a severe infection. So by the time they're showing a fever, then things have progressed quite a ways. However, many older adults with serious infections do not develop a fever at all due to their weakened immune response. Remember, a fever is a response by the immune system. In older adults or even immunocompromised people, that response may be weakened or attenuated, and they may not show signs of a fever if they're in those conditions. With the integumentary system, wrinkling and loss of skin resilience are the most visible signs of aging. The skin becomes thinner, drier, less elastic, and more fragile, causing wrinkles and easily leading to skin tears. There's also a thinning of the subcutaneous fat that makes bruising much more common. Elastin and collagen levels decrease, making skin tears much more likely. Older skin bleeds more before clotting due to the reduced elasticity, and skin may tint when checked for turgor, even without dehydration. So as patients get older, the skin turgor check is a less reliable indication of dehydration. Subcutaneous glands will begin to produce less oil, causing the skin to become drier. Sweat gland activity declines, reducing the body's ability to regulate heat. Hair follicles produce thinner hair and may stop producing hair altogether. Follicles make less melanin, resulting in gray or white hair. Melanocytes in the epidermis decreases, leading to paler skin and greater sensitivity to sun exposure. Remaining melanocytes enlarge, causing benign pigmentation changes, especially in sun-exposed areas. Increased capillary fragility can cause purple patches called purpura on the skin. Epidermal cells regenerate more slowly, so skin renewal slows down. Fingernails and toenails become thinner and more brittle with age. Poor peripheral circulation may thicken and yellow the nails as well. Improper toenail care can lead to infections, and infections combined with peripheral vascular disease or diabetes can result in amputations. Homeostatic functions decline with age as well. Illness and injury is more likely to cause rapid deterioration in older adults. The thirst mechanism weakens and there's an increased risk of dehydration. Temperature regulation becomes less effective, making older adults more vulnerable to heat and cold stresses because their bodies don't respond well to those. Blood glucose regulation worsens with aging. Elevated blood glucose levels are common in older adults, and moderate hyperglycemia is usually not harmful, but overly aggressive treatment can cause a dangerous hypoglycemic level. Bone mass typically decreases in both men and women as they age, and bones become more brittle and more prone to fractures. Joint problems arise as tendons and ligaments lose some of their elasticity. The synovial joint fluids thicken and cartilage cushioning in the joints decreases, leading to stiffness and pain. Height decreases and posture changes due to the narrowing intervertebral discs and vertebral compression fractures. The joints lose flexibility and may develop some stages or forms of arthritis. Muscle mass and strength decline with age. And prolonged limited mobility can cause muscle atrophy as well. Older adults are more prone to bone fractures from falls. Falls are more likely due to joint stiffness, the loss of tendon and ligament elasticity, and muscle weakness than they are anything else. Tripping is a big concern because, as mentioned earlier, the reflexes are slower. They're unable to kind of catch themselves or correct. And the joint, combine that with joint stiffness and weakened muscles and those kinds of things, it's a bit of a recipe for disaster when it comes to tripping. Many patients struggle with self-care tasks that require fine motor skills and hand strengths, such as taking medications and wound care. Physical activity can slow the loss of bone density and muscle mass, so it's really, really important for older adults to still get physical activity, get up and do things, and remain active. This will help with, stave off a lot of these issues. Those with larger muscles and a history of physical labor are less affected by these musculoskeletal declines. And gentle, consistent use of arthritic joints can help to reduce the pain as well. So I know it all sounds pretty terrible, but once again, they're just talking about the normal process of things that happen. Hopefully you guys aren't, dreading your senior years. These are just the normal part of the aging process of things that happen. And these are more along the lines of worst case scenarios. If older adults are active and they're getting out and they're doing things and engaged, and whether that's planting flowers in the garden or doing those kinds of things, just being active out doing things makes a huge difference in many of these things. Keeps the brain functioning, it gets the muscles and everything working, it gets the heart gets a little exercise, the cardiovascular system gets a little exercise, eating right, and all those kinds of things play a big role, not only just in the aging process, but as at 65 and older, but leading up to that, it's really important for those things as well. So you're going into that stage of life with all of the things kind of in your favor. So, all right, so that's kind of the background of things, how things work. We'll start to dig into some more specific things related to our geriatric patients in part 2.